Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited, customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Conception, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care is a model of medical practice that allows doctors to be the best doctor they can be for their patients and to help their patients to be themselves instead of being a widget in a system. So my name is A. Patrick Jonas, A for Arthur. My dad was Arthur, his dad was Arthur, and none of them were called Arthur, but I'm called Pat. Pat Jonas, board certified family doctor, but I'm happy to be in direct primary care in Bellbrook, Ohio now, and this is my DPC story.
Today's episode was recorded live at the Bellbrook Open Arms Free Clinic, the day after the Ohio State DPC Unsummit. That's the state-focused direct primary care summit that started 11 years ago, where doctors like today's guest, Dr. A. Pat Jonas, and last week's guest, Dr. Lily White, have been inspiring the next generation of DPC physicians. Now, more about Dr. Jonas. He is a treasure in family medicine, a physician, a scholar, a warrior, and innovator who's been practicing for over 4 decades. In addition to serving as medical director for Open Arms Free Clinic, he also serves as medical director for Gem City Holistic Wellness and runs a part-time DPC practice called Neighborly Integrative Health. He hosts 2 podcasts, Dr. Synonymous on Spreaker and the Neighborly Health Show on locals.com. You'll also hear him mention Larry Bauer, former CEO of the Family Medicine Education Consortium and a fellow champion of the patient-physician relationship. If you enjoy this conversation, don't miss the extended interview on our My DPC Story community, where Dr. Jonas shares about launching nonprofit clinics and gives practical tips on applying for grants and other creative ways to fund nonprofit care.
I was at Hershey. We had a faculty development grant, the first one ever. Tom Lehman was one of the founding fathers in family medicine, and he helped to found the Society of Teachers of Family Medicine. And he wrote a grant to get a faculty development coordinator, and somebody from the University of Dayton accepted the job, and the next day called and said, oh, I forgot to tell my wife that I was doing this, and so I'm not going to be able to come out there to Hershey, Pennsylvania. I called a guy in behavioral science. He says, we got Larry Bauer. I said, well, who's Larry Bauer? He said, well, Larry Bauer is in Virginia. He's in prisons. And I said, he's an inmate? He said, no, he helps prisoners. He's a behavioral counselor, social worker, working with prisoners. He's being squeezed or crushed, and he's got to get out of there. So he calls like the next day or something like that. And he asked me about 2 or 3, what's family medicine? And I said, well, it's like general practice, only much better. And he came up and everybody had to interview him. And the one guy who was the most skeptical, he says, what makes you think you can teach doctors? And he says, I teach prisoners, and I can teach anybody. And the guy loved him. So Larry Bauer came there, and then started the consortium and the FMEC and all those other kind of things, and affected like how many hundreds of thousands of patient lives because of his insight about what he did with the faculty development coordinator job and starting the consortium of all the residencies in Pennsylvania and then the Northeastern United States. And he and I worked together for years doing workshops and all kinds of other things in faculty development and writing things and whatnot. And then he went there and we were at Ohio State together in the war zone for 4 years. The DPC model, he brought it to the FMEC annual meeting in Baltimore. And I was at all those meetings because I was on the founding board, the founding treasurer of the Family Medicine Education Consortium when it was Northeast Regional STFM. And I'm at that meeting and I says, whoa, I could do that. And there was a rushing of the stage like Larry had never seen. And he said, there's something here. We got to do this. And so I started it the next July as a track in my practice. Had a lot of restaurant people and some international people come in, delightful, huge family from Sri Lanka and some others. And I said, wow, this is really cool. And I understand how it works. And then it was 6 years later, I cut the insurance out and just did the DPC, learning along the way, and then presenting at that meeting, like the next year after 2013, presented at the meeting. And Larry took the 5 of us presenting about that into his room and sort of locked the door almost and said, we have to do something with this. Yeah. So he planned the summit, the first summit in St. Louis. And that was like 125 or so doctors jumping up and down, happy, laughing, smiling. It was awesome. It was sort of addictive. And at that meeting, I announced that we were going to have the first Ohio Unsummit. I didn't want to show disrespect for the summit in January of 2014.
We're sitting in your Bellbrook free clinic around the Dayton area for those listeners who might know that more than Bellbrook. But we just came from the 11th year of the Unsummit. It was a great testament to you guys. A medical student who's been to the Unsummit now twice in a row. She commented that she asked, is this population at the Unsummit representative of what you see in the nation? And I said, absolutely. You're a medical student. Sitting across from you as an intern in family medicine. And then you have somebody like Dr. Hoke who's been open 5+ years. You have somebody who's opened 7 months. You have somebody who's interviewed 250+ doctors from California, like a totally different state. Mm-hmm. I mean, there's so many good things that I loved in that answer to this medical student. And that's because you guys have kept this up. And you and all of the other doctors at the Unsummit were still happy. And the idea that you still find joy in medicine, I think is really amazing. And that's what I love being able to highlight in this, because there's a lot of people, even fellow Ohioan, Dr. Chun, he's been on the podcast and he had his profession take him to multiple different iterations of practicing as a doctor, urgent care, occupational medicine, and then finally his own clinic. And yet he still went to DPC. So let's go back to when you first became an attending. What was the world like in terms of the insurance? And I wonder if that is tied to how come you can still persist in being happy and loving your job and loving teaching other people, because you knew what medicine used to be like compared to the people who are graduating residency now. They don't have the same perspective.
Right. So I've been blessed my whole life, actually, but the family medicine, I always loved family, and it's a family medicine especially. Okay, I know family, I could do family, and I did families only in my practice for 37 years, but starting the practice was after training at Hershey, Pennsylvania with Tom Lehman, who was a great role model for thinking. He was a clinical wizard, and he had difficult patient rounds once a week with the third-year residents. And so whatever kind of difficult people there were, he could show us how you can interact with people about anything, but also had the great story about delivering the bride's baby at a wedding at the Hotel Hershey. She thought she just had the indigestion at the reception. So great stories like that in some family medicine, and seeing those traditions of general practice moving into family medicine and saying, okay, we got the family, and starting practice in I thought okay, I want to practice for about 10 or 11 years and then go academic, because then I would actually know something that I thought you had to know something before you were teaching it.
others.
So I'd know the specialty and how could be practiced. So I went to the Granville Medical Center with a couple guys who had, it was a suburban, Granville, Ohio, Denison University was right up the hill. And I managed to pick up the Denison contract after a couple of years. So I became the director of the campus health center and the head team physician, doing sports medicine, my regular practice. So it kind of every 4 years shifted a bit of my scope of practice because something else showed up. And just like the free clinic, it was perfect with direct primary care because you have the flexibility to actually make your own decisions. So every 4 or 5 years, as an independent practicing doctor, I did that. But for 4 years, I was on the faculty at Ohio State because we restructured the Department of Family Medicine. John Lombardo, who was the team physician for the Cleveland Cavaliers on OSU, the class behind me, he called and said, hey, they called me and wanted me to apply for the chair of family medicine. But I don't think I could do that without you being the vice chair of the department. And I said, well, we can't do it without Larry Bauer. So that was an interesting project to kind of take what we had learned from our faculty development experiences at Hershey Medical Center and trying to connect into the early definitions of family medicine. Tom Lehman was hired by the guy who started the Hershey Medical Center to start the Department of Family Medicine, and especially that didn't exist, and a residency, and especially that didn't exist. So a great role model for making things out of vapor, and for change and shifting and having fun.
Yeah.
So working with Larry also, I'd find with my first practice saying, okay, what are my observable, measurable, reproducible outcome goals that will have me. So we decided one of the goals was to have 5 people every day say thank you. So if I did well enough, they would spontaneously say thank you. And that would be feedback that I was connecting to them well enough.
Yeah. And
I also taught clinical decision-making forever. So worked up models of that in the residency program and studied it all over. Larry and I went to a problem-solving workshop somewhere in Atlanta, Georgia or something with some of the wizards in clinical problem-solving and came back and tooled up some models. What is the office visit in family medicine? So I've studied that for now 50 years. What are the elements of it? What's the content? And I've sort of evolved over the years, but slowly but surely understood that I'm trying to help the patient be the patient, be themselves, and to connect to them as a human being. As if I'm just a doctor and they're just a patient, then we don't have the best connection possible. But 2 humans connecting is much more fun, much more interesting. So every 4 years we shifted a little bit and found the DPC thing and said, okay, this is beautiful because we can continue to do real family medicine and really respond to people. As the systems were squeezing. At 4 years with Ohio State, and they were, the duck came down and said, it's time for you to leave. I said, okay, I'll go. Came down to Kettering Medical Center, was just starting family medicine education. And then Larry went out with the system to make the network. And the other part of the system suddenly was squeezing. And they said, well, we need to go this other direction. And they were going to terminate somebody that I had just recruited and hired. And I said, well, no, don't worry about that. I'll go. So I asked my wife, where do you want to be? I've started 6 practices. So where do you want to be? And she said, well, I love my mother. I said, okay, I'll start a practice here. So I started the Family Health Connections Incorporated in 1999. 3 months later, whatever, somebody called, said Central State University needs a campus health director because their guy just sort of realized he wasn't going to show up this year. So he got to pick up an HBCU medical directorship, organized that, brought in our nurse practitioner, delivered them 3 times the services that they had already for the same contract dollar figure. And it was just the family medicine, using family medicine model. That's how I got the Denison job. Denison guy left, and he called me from up the hill and said, hey, we hear that you're interested in looking at our campus health center. I said, yeah. And I went in and they said, well, tell us, what do you do? And I said, this. And they said, wow, that's what we need. Basically, it was family medicine. So we had family medicine in the Denison University Campus Health Center, and for sports medicine and family medicine the model fits everywhere. So it flex bed, twist the bottle from Denison, Granville Medical Center, Ohio State University, out of Ohio State, Kettering Medical Center, started a new practice. And then, bought a building and expanded a bit there. But then I recruited somebody, Cheryl Applin, who was at that meeting Saturday. I helped to train her when she was a resident at St. Elizabeth Hospital in Dayton. And I called her and said, Cheryl, what if I got this Central State University Campus Health Center, and you would be perfect here. And she loved it. She loved the campus health community. And I said, good, because you're going to be the next director here. We restructured it, and then it was out of there and picked up whatever the next thing was. And then DPC hit. I said, okay, DPC is it. So periodically you do a new model, restructure, redirect, but it was still families only in the core practice. And I went to the family and family medicine meetings at Amelia Island, Florida. They had about 10 of those or so. And these were the family fanatics. At one of the meetings, the family therapists were there. And so you learned about family structure, function, family life cycle, and all this family research. Wow, this stuff is good. And why isn't everybody doing it? Because the family is so beautiful and rich. And it's the core decision-making model in America, whatever a family is. So I'm not sure what a family is, but it was the core of my practice until a few years ago when I was shifting. I said, okay, we're not going to do the family's only thing for the DPC the last couple of years. So we had odds and ends people because the pandemic hit. As the pandemic hit, I said, okay, let's pivot the model to treat people with the coronavirus because other doctors were forbidden to treat the virus with antivirals. And there were good studies from the world showing that they were effective. They were effective cocktails of chemicals that one could treat the coronavirus with. And for whatever reason in America, most of the doctors were banned from doing that. But I wasn't because I was independent. I'm a deep direct primary care. I said, okay, we're going to offer memberships for a month to 3 months. And so people started calling from all over the state, treated over 900 people with the coronavirus. And it was just fascinating. I treated doctors at the Cleveland Clinic. And everybody would say, well, who's your doctor up there? And what's their approach to the coronavirus? So I got to hear about the whole state, what was happening with the treatment of people with the coronavirus or at risk for. I treated 5 people with chronic lymphocytic leukemia. None of them died. It was just an interesting thing, but it was a flexing the DPC model. So still having fun though, because the essence of it is the patients. It's like when Cal Ripken hit the home run at his last game ever. It was amazing. And it was all about the fans. Yeah. Where if you're a cab driver, it's about the fares. If you're a baseball player, it's about the fans. And once you realize about the patients, then you are the music. So the DPC package is a way to have more time to deliver people to be themselves. And along the way, I was on the Commission on Continuing Medical Education in the American Academy of Family Physicians for 7 years, chaired it the last year of those 7. And halfway through that, the world started to change, and the CME landscape was asked to give credit to international type subjects that may not be the practice of medicine. So we had to sort of define the boundaries of the practice of medicine and got to redefine the CME with things where certain types of evidence would get you certain types of credit. And so a lot of the evidence-based things were integrated into the CME sphere. And at that time, I drove by the Ohio Academy of Holistic Health one day in Beaver Creek and said, what is that? And walked in. So what do you all do? And they said, well, we're like the biggest holistic training center in the state of Ohio. And all that stuff that I had learned about that wasn't the practice of medicine or was becoming was right there. And they said, why don't you become a medical director and learn more? I said, well, okay. So I became the medical director for education for the Ohio Academy of Holistic Health and learned 11 different modalities of holistic practice, and slowly but surely figured out which aspects of that was the practice of medicine, how to fit, what was actually alternative, which was not the practice of medicine, what was integrative, that was fun and interesting and fun to help the patients, because then the patients were having a lot of chronic fatigue and other things, and the fibromyalgia and pain came along. So I said, well, I got to learn pain. So I learned pain and taught the pain management course at Wright State Medical School for 6 years, along with full-time faculty. I'm a clinical faculty. And Phil Whitaker and I taught that course, and then did workshops at the FMEC annual meeting, I think 5 years in a row or so, about teaching pain management. And that's kind of evolved and devolved up and down. And so I had a bunch of people with chronic pain, and then a bunch of them turned out to have the Ehlers-Danlos syndrome. So I learned about that, went to their annual meeting of the Ehlers-Danlos Society in Las Vegas, where there was like 500 EDS people and 50 doctor types staring at them for a weekend. And then I said, okay, I learned something there and I already knew some things about pain and suffering, but slippy, slidey, stretchy, bendy, twisty, challenging population. And then this free clinic, there was something happened at a church I was going to, and I realized I had to leave that church. So I walked into, it was a Methodist church, so I walked into another Methodist church down the street and say, hey, how is everything here? And they said, well, what do you mean? I said, well, are you still having fun? And the woman said, well, ask our preacher. She's right behind you there. So are you still having fun? She said, we are still having fun. Then she introduced me to the faith community nurse, Mary Ann Stone. And Mary Ann Stone said, oh, you're a doctor. Do you want to be on my health committee? I said, yeah, that sounds good to me. And then within 2 weeks, she said, I'm going to start a free clinic. And do you want to help with that? I said, yeah. She said, well, God called me. She was 75 years old. She said, God called me to start this free clinic. I called my daughters and told them, they said, what? We thought you were going to tell us you were retiring to a beach or something. So she got the call to start the free clinic in a not a poor suburb of Dayton. So a lot of people said this doesn't make sense, but she did the needs assessment and found there's all these people around. So, and she didn't know it couldn't be done. At our first business committee meeting, I was on multiple committees on the way to opening the free clinic. The first business meeting, she was talking, and I'm thinking, she doesn't know it can't be done. So I think it's going to happen, because the IRS blocked her about 3 different ways and some other kinds of things. Because there was some, it was one of those times in America when there's these different factions, there's these factions that kind of rise up and play games. So she made it through that, and we started the free clinic, and the DPC model fit nicely with that, because the DPC doctors can flex, bend, and twist their lives and their models and take care of people. And they like these chronic pain and Ehlers-Danlos and the COVID and whatever comes along, they can flex and bend the model and their scope of practice as they wish to respond to things or not respond to things. So the free clinic fit, and then said, okay, the beauty of the Unsummit needed insurance to cover the meeting, and the free clinic has insurance that covers medical meetings. So we become a sponsor of the Unsummit and profit financially from it, and they benefit by having the insurance. But then also every year, everybody at the Unsummit gets to hear about free clinics and about how you can do a free clinic thing. And partly it can fill in the scope of practice. So if somebody has a certain, if they don't have, or they can't fit Ehlers-Danlos type patients in their regular practice because of their flow, their rhythm, or whatever, they can fill in the scope of practice by seeing those kind of people at a free clinic. The people who are discarded and wiped out and crushed and homeless and whatever, maybe they can only take a certain number of those in their free clinic, in their day job. But so it fits nicely with the DPC model to have the free clinic. It's unending. I'm still having fun. I'm almost 79 years old, and my wife is whispering about it should be done, but I'm still having fun. And the direct primary care model, though, fits so good also with end of career, so people can sort of taper down and still have fun and still take care of people, and then go to the Unsummit and help to recruit people. So there was somebody at that meeting who is thinking about our board of directors that I used to chair. I'm still on the board of directors for this place. Agreed that we're not using it. Since we're not using it during the daytime, we have night clinic. we could rent it to somebody to do a direct primary care and use it for a incubator for DPC type practice.
Amazing. Very inspirational and so many questions. One of the first that comes out with you sharing this rich history of autonomy, feeling like something wasn't working, making the next decision, and really, like you said, having the patients guide where you went so you could serve them so they could be themselves. Knowing that you talk to so many people who are earlier on in their DPC journey, medical students, residents, and people who are in their first, few years of DPC. What are some of the things that you ask them about in terms of thinking about, is what you're doing right now going to work for you so that you can truly be the doctor who you were meant to be, called to be, whatever it is? Because I think that that's where it's one thing to see a DPC doctor doing their thing, but it's another thing to really just have a moment to think about, are you getting joy out of what you're doing? How many patients are you seeing a day? What types of questions like that are you asking people when you have conversations with the future of DPC?
Stay with us. We'll be right back.
Are you looking for the latest medical guidelines and research without the hefty price tag? Meet Open Evidence, the free alternative to UpToDate that keeps you informed with real-time updates on medical guidelines, research, and best practices. And here's one of my favorite game changers about Open Evidence. It will notify you when new guidelines affect the question you've already researched. No more outdated info, just smarter, faster, and always current. Join thousands of medical professionals choosing Open Evidence for free. Try it today by checking out the link in the show notes. Open Evidence AI. Stay informed, stay ahead.
Well, I think in terms of taught practice management for 45 years now. And so Larry and I worked on that together for a decade anyway. And we said, okay, the people have to define their philosophy of care. So what's their philosophy of care? As a physician, what is it that I believe? And then what's the scope of practice that may deliver that for them? And what's their calendar look like in which they schedule those kind of things? Like I said at the meeting, put your vacation in there first. And there was actually Lily came through here to our free clinic, and the intern from Ohio State came through here. The students come here, I mean, like I said, point out to them, there's 127 specialties and subspecialties, and your mirror will know which one is you, but you need some career Windex for a little while to spray on that thing, and you'll get input from different people, but nobody perfectly knows what specialty you really are, and it's not that easy necessarily to know. So you kind of go through experiences and say, wow, what did I like there? What kind of rhythm? So life's about rhythm, and one of our concepts here is to prove the patient right. And it takes the clinical decision-making. The note is our differential diagnosis model is SPIT, S-P-I-T, serious, probable, interesting, treatable. So if you spit soap, it kind of makes the note pretty easily. And then under interesting is the patient's theory. And under patient education, that part of the differential diagnosis drives you down to say why they're right. Or that it looks like Google missed it this time because you're over here. But it's great that you care enough about yourself to look things up, because we're a partnership. We're working together to help you to be you, and you know who you are and we don't. And if you are you and you say, I'm me, we just share, we're happy. So a lot of that goes into like the career planning kind of model. And I tell the students, you want to be able to do your part. There's patient care, administration, research, and teaching are major aspects of medical career. And there's others, but if you spell that backwards, it's trap. So you could do the career wrong and you could be trapped, or you could do your part. And I use that as a 20-year career planning thing, PART, 0 to 5, 5 to 10, and would say, well, how many, if you're going to be a certain thing, the military get to plan like this when they look at their career planning, because they have these schools they go to and then they apply it and then they go to somewhere else. So using that kind of understanding, since I was in the military for a little while, say, wow, you can plan the career. So, okay, I want to do a whole bunch of patient care initially because I don't know anything. And then I figure I'm going to start to pick up a bit of an admin job and be in charge of something or other, and then maybe start a practice or a network or what have you. So you plan your career, you have these little models. I'm a model builder. Larry and I made a bunch of models together and then modified a couple, like polar with an interact with the patient, position, observe, listen, ask, and respond. And that R is really important because a lot of doctors don't respond to what patients say. And the patients may often say, he wasn't listening to me, or he didn't hear me, or whatever. And we know the doctors do listen and they do hear, but they're whatever the judgment is, they could respond and say, hey, I love that, or I'm thinking you're not quite with where our concern is over here. Let's be over here for a little while, then let's go back to that. So we had those models to help people to have that one step that maybe they would otherwise overlook. So it's career planning, starting with philosophy of care, scope of practice, schedule, and then celebrations. How often can you celebrate? And we got to had the patient-centered medical home in the year 2000, went to the meetings about that, said, okay, and after about 4 years, it clearly looked like the payment-centered medical home. They were just trying to figure out how to get enough money into primary care such that people could pay their student loans and by going into it. So it was all about the doctor. And said, well, this is not fair to call it patient-centered medical home. But it's all about student loans. And I ran into a guy at the base who was doing human centering. People have these computers and they're being dehumanized and they don't understand how to have a human interface with the machinery. So it was a socio-technical interface was his thing. And he told me about human centering. We studied it a little bit, wrote a paper, and he presented it at Systems Engineering International, something or other. But it was, the model was to detect, respect, connect, detect, correct, and reflect. It was 6X. It was my ACT year. I presented that at the FMEC meeting, saying, here's the human centering. So that protecting is like protecting them and you and the time needed to be able to do the right things. And respecting you have to respect yourself and respect them. You're both humans. And then we're like teaching medical students, so, okay, as soon as possible, get the patient to teach you something. So when they're teaching, you're hearing their voice tone and so forth, they're genuine. And that's who they are, so that you remember that because you want them to be them. And if they're kind of more uncomfortable, phony, superficial, or whatever during another part of the exam, you're like, okay, I'm not getting the best information because somehow I turned them off or they got afraid of something or whatever. So there's those little steps. So I'm a continuous, curious learner and then a model builder. So the curiosity is, okay, well, there's a lot of this. So how do we roll it back into a model and teach that? So a lot of it comes down to the teaching stuff. So I can learn better if I can teach.
That's awesome. When people are in your ecosystem, they're around you, they're able to talk with you, shadow you, work clinically with you here and at in all of your iterations of practice. I'm sure there are still questions of, but I couldn't do that because, and I'm wondering what are those common fears or hesitancies that you hear from somebody that they may work through at some point. But I mean, even Dr. White shared she was not sure still. And she'd absolutely been one of those people in your world.
Yeah.
And it was one moment when she was coming out of the Redwoods that she was like, wow, like it's literally clear for me that I cannot be doing medicine in the way that I went to residency or in the way that I was taught in residency.
Yeah. So part of the fun of that is that somebody says, well, I don't think I could do that. And my first response is, well, it's not for everybody. So that generates a common human response. It's wait a minute, why isn't it? So it gets them out of their trance-like state. And they say, well, wait a minute. And then they want some detail. Here's who I am and what is it? And how does that work? And then I talk about the differential diagnosis. Say it's not about your cell phone number like the doormat people were talking about. I give everybody my cell phone number. They call me 24/7. So that's not the essence of DPC. The essence is you can think and you have time with the patient. You have a differential diagnosis that is much better than anybody on the planet. And so you keep learning and you keep being curious about things because your brain has the mutant. I mean, tell the medical students, you have a mutant brain. You have more thoughts per unit of time than all kinds of people. And you have an opportunity to actually be able to use that mutant brain. So you're not feeling wiped out or something because you're being ignored, because that mutant brain can go. You can always go down to mitochondria, to electron transport chain, to first complex, depending on B1, second B2, third B3, cytochrome C. And you can go back to that every day, every patient, because you have the time, you have the brain. And you shockingly remember and say, oh my gosh, the mitochondria is important in this because the mitochondria just shifted into immune. So let's get them some infrared. So they got expansion zone water, which generates the energy that the mitochondria is not generating. And then the person stays effective and functional every day, every patient. You can go back to cell physiology if you want to. You can get genomics, methylation, whatnot. So a lot of students say, wow, it's overwhelming. Well, it's overwhelming because everything is overwhelming if you look at it in certain ways. But if you have some models and you realize that one of God's great gifts to us was 7 plus or minus 2 bits in short-term memory. So we can't have anything in short-term memory. That's all we really get in the moment. So you have your 1 bit for your clinical decision-making, or maybe you got 2, and suddenly you got a space with the patient, and you got 4. And you got your differential diagnosis and all kinds of stuff and whatnot, because there's a thing on your EMR that goes off that says the visit's almost over or whatever if you're in certain systems. So you can actually take your 7 and use them different ways, and then allow your unconscious mind to do a transderivational search of an infinite array of phenomena that goes back to your birth and then some, without having to actually press it. You allow it. So once you learn how to allow your brain to mutate with you, you can have more fun than you can stand. Yeah. So it's all doable because the 7 plus or minus 2 is all the patient gets. It's all you get, and you're engaging those, and you're calling up other things, and you're respecting and honoring continuously because of the quest for truth. And eventually, though, like I tell the students, they all die. So you're not going to do eternal life with this medical stuff. So you don't have to have a God complex. In the first years, I say, you're not allowed to know this yet, but they all die. So the good news is there may be no right answer until you go to medical school tomorrow. There is a right answer there, because you got to have those boards and all that stuff. But with a human, it floats, it flexes, it bends, it twists. You got 60 trillion cells, each of which have 100,000 chemical reactions a minute, according to many studies or whatever, or to some graduate student's paper. When you got that kind of dynamic, it is not understandable. So we actually can't understand it. We act as if we sort of do, but as we honor the beauty of the creator, or whatever we want to see as the ultimate, the infinite, we can have a great sense of awe and celebration that we get to play with little pieces of it.
I love that. Separating a person's decision to lean into DPC from that DPC isn't accessible to all patients. You touched on this a little bit, because as a person, even if they have their own DPC clinic, they can still do things at no cost. If they want to create a nonprofit, there's different models. But especially because you were 7 years and the head of the CME for AAFP at one point, I just think about, even back in California, I have so many people that say, but DPC is for rich people. So, and I love the laughter again, especially when you're talking to colleagues who might not, DPC is not at all in their professional journey, but you're talking to people who are our colleagues in fee-for-service. What do you say to them if they're saying these things? They want to engage to learn more, but they really are uneducated about the model and what it does, not only for us as physicians, but it does for patients who do not have $40,000 a year to pay their doctor plus bill insurance like concierge medicine.
Yeah, so there's all kinds of models of medical practice. And DPC is merely a business model. All models have good and bad parts. All models have the potential for incredible ethical behavior and incredible dishonesty and thievery. So none of them are the holy grail. And so people float model to model to model and decide, okay, which model fits my quest best at this particular time. It's like that. My philosophy of care. Is there something about any of these models that would help me with my philosophy of care, my scope of practice? And so DPC is a good model for people to be able to escape from being crushed and depressed and even suicidal in a small subset of people. It's an inexpensive way for people to escape and to start again with some of their same patients. And then they say, okay, can I be the doctor that I thought I was being oppressed from being across the street? So it's not for everybody. Doctors, though, with the mutant brains, they want to think. And the doctors I know want to think, and they love thinking, and they love helping people, and they know they're smart, and they've had that feedback forever. Some of them may not believe it enough. But that's the thing that I think the DPC delivers is the ability to take that mutant brain and that skeptical burnout doctor now and allow it to kind of reboot and to connect to patients in a way that they used to be able to initially, but then they got smushed out of with that contract renegotiation and those extra patients and whatnot. But it's not for everybody. So I tell them it's not for everybody. And you're right. We don't actually walk down to the homeless shelter and say, can we sign you up for a DPC? But we could. We just get the benefactors and say, okay, benefactors, I want to have the DPC thing working over here. It's this kind of thing. I said, wow, that's like nothing. Okay, cool. So let's put it in the bank and let's go start to deliver, because that's how easy it is. That Modesto model was really cool with the benefactors. So the model can flex, bend, and twist in different ways, but it can deliver a doctor back to their own brain, back to celebrate their dream. And so it's a dream building thing with the doctor. So you align with your dream. How well you align with your dream? Well, this is one of those options that gets you to thinking, can I regain part of the dream, or do I have to become the medical director for the hospital, orthopedic clinic, whatever, or something, because I've got no other options?
And I think that's so relatable, especially to a lot of the listeners who are, thinking about dipping their toes into the DPC Kool-Aid, because a lot of people will take the admin role, will cut down to half-time FTE. And my best friend from college and I have this conversation all the time. She's internal medicine. And I'm like, I'm glad that your first week is, joyous in your admin/patient care role, but it is very interesting when people are wherever they're at in their journey and they're sensing that they can't do what they've been doing and they try to do different things. And I think this is that avatar of doctor that I talk with very frequently, who's in the fee-for-service system, but who is at least open to hearing what is DPC. And I think that, and I said this so many times at the Unsummit, but I'm so proud of these younger medical students and residents who are asking. I had no idea what it was when I was even in attending. Mm-hmm. So it's amazing to see people leaning into exactly what you're talking about. I think it's beautiful. What's your culture? How does your scope of practice protect that? And how does the time in your practice allow you to do all of those things? And I think it really, that is why we see word of mouth growing our practice, because every patient is going to receive it differently.
Yeah.
And so I think that I love the way you put that.
There's some little things that afflict everybody, and doctors also, that need some unflicking somehow or other to get back on track, back with the dream. And the DPC doctors could have a little more time for dream building. But I like the career planning concept, though, is one. How's your career? And that mutant clinical brain for the clinical doctors. And there's doctors who are admins who are brilliant, and they need to know, too, you get your DPC doctors hired in your DPC track, and suddenly you got all kinds of employees in your system who are getting better health and better medical care and better outcomes and whatever, and your system works better, and then you have to decide if you want to shift the system in even bigger ways. But you can get homeless people DPC, you get all kind of people DPC. It's just a matter of creativity and piles of money. So if the money goes to the right place, you fund all kinds of things.
Yeah.
So I want to do a project for grounding mats here. We got the sun, we got grounding mats, we got blue light glasses. And so we get donors. We say, okay, we want to get 100 grounding mats, and because we want more electrons poured into our people. It's a simple concept, and here's the videos, here's studies. And we want to get blue light glasses for a certain percentage of our people, and have some things about sunlight. And we got walking trails around here and some other kind of stuff. The program that Lily started, the Paths to Wellness, Dr. Murphy is going to speak within the next 2 months at the Bellhop Cafe. And then I would intend to take the medical students to his practice 4 miles that way, so they can see how his dream has been operationalized. And okay, this is just one dream, one way that you can think, because you take your dream, and I tell them, I'm just holding up mirrors for your career. Be careful listening to that third-year medical student try to push you into some specialty now before you hear about the 127. And before you hear about differential diagnosis, so we teach them the spit soap, improve the patient right. They say, what? I said, here, and we have this piece of paper that has all that on there. It's one piece of paper. And okay, so what you're saying is you got this, so let's go figure out something that is serious that can kill them. And say, every patient, every day, I think about what could kill them that shows up this way. And they say, what? I say, yeah, every patient, every day, because I'm old, I've had patients die. Or sue me. The interesting thing could be, oh, what did somebody sue me for that sounded just like this one time? Or it depends on how you're thinking as a doctor. But that interesting category under SPIT gives you a lot of flexibility, but especially the ability to connect to the patient down to the patient education moment, where you have to tell them how brilliant they are to figure out what they got when you probably wouldn't have if they hadn't to talk to their sister or what have you. And there's a celebration moment there, amazing human connection and honoring, and hopefully not dishonoring.
Yeah. Well, thank you so much, Dr. Jonas, for sharing about all of the things that you have been through, that you continue to be a part of, because you are absolutely helping the next generation of DPC doctors and helping this movement as a whole continue into the future.
Thanks. I'm still having fun, and hopefully it's awesome what you're doing, because people like to tell their stories, I think. And then people like to listen to other people's stories. And that's what I tell the medical students here. So you just ask about 2 open-ended questions, and the story is told, and medical stuff just drips out of it. So eventually, as you know more medical, you'll know what's the medical stuff. And then you just ask a couple clarifying questions, and you're done. And they think they just told their story. But you learn about humans and about how beautiful the human condition is, how amazing people are, and how you get to celebrate every day and cheer for people. But that's the beauty of the DPC. There's more cheering time, more honoring time, more awe time, and more safe time.
Thank you for listening to another episode of My DPC Story. If you enjoyed it, please leave a 5-star review on your favorite podcast platform. It helps others find the show. Have a question about direct primary care? Leave me a voicemail. You might hear it answered in a future episode. Follow us on socials at the handle @MyDPCStory and join DPC Didactics, our monthly deep dive into your questions and challenges. Links are at mydpcstory.com. For exclusive content you won't hear anywhere else, join our Patreon. Find the link in the show notes or search for My DPC Story on patreon.com. For DPC News on the Daily, check out dpcnews.com. Until next week, this is Marielle Conception.